Okay, guys, we're going to get started with core content.
All right, good morning. I'm Jordan, PGY3, presenting on the Heme-Onc core content. Today we're going to talk about reversal agents of warfarin, the NOACs, as well as briefly on dabigatran. And we're going to start with a case today, presenting with Dr. Wiener. So case number one, we've got a 41-year-old man with a history of AFib. Presents with occasional palpitations, but he denies any shortness of breath, no dyspnea on exertion, no chest pain. He's also got no fever, cough, and no leg swelling. He does state he's on a blood thinner, but he can't remember the name. And his vital signs, his heart rate's 81, his blood pressure is 100/60, satting 98% on room air. Labs are sent, x-ray is taken, and then you find a prescription for warfarin 2.5 milligrams in his chart. Lab calls overhead, and you pick up the phone and they say that the patient has an INR of 10.4. So first, what's this patient's problem list and what are your next steps? So first, problem list. This is not rhetorical. Problem list? Dyspnea. I think he denied dyspnea. Okay, we'll give him just a slight dyspnea when he sprints. Supratherapeutic INR, or we could supratherapeutic INR. So coagulopathy, hypocoagulability. I had to figure out how to spell that. What else? Palpitations. Yes, palpitations is his only symptom. Truly. His history, maybe the palpitations were caused by his history of paroxysmal AFib. And then I think our question is, does he have a bleeding diathesis with this INR of 10.4? So what are your next steps? What would be just some popcorn thoughts on your next steps? What would you do next? Yeah, maybe make sure it's not bleeding. How so? Physical exam, more questions. Noah's doing this. Yeah, sure. And then what about what about lab tests or anything else? Exactly. Right. So CBC, we run and check our CBC to see what the hemoglobin is, and then we also make sure we drew a type of screener or sent one off. Okay, so more information on this patient. So he denies any orthopnea or PND, but he does feel generally weak. And he said he's had some good amount of bleeding from the bottom for the past month. It's all fine, though, because he has a friend who finished med school who said go sit in a bathtub, and that bleeding from your bottom will resolve. He tried, but he figured he hadn't spent enough time in the sitz bath. So he now recalls that he's not taking warfarin, but he's actually taking apixaban 5 milligrams. And when you go back to perform your DRE, you find positive melena. So coming back to our next steps, how does this change? What has changed? The patient now has active bleeding where before that was not on the problem list. What has changed about your next steps? Or just some thoughts? Yeah, so we might be starting to think about reversal agents, and we know, and we'll be talking about that in a moment. Would you say this bleeding is considerable? We don't have a hemoglobin yet. Is this major bleeding?
His pressure is 100/60, which is a little soft.
His pressure is 100/60, so that can be concerning. And we'd like to know, what his baseline pressures are. What is it? His SAT? Orthostatics. We would get some orthostatics if his pressure drops. Then we might be more concerned that he's bleeding. The American College of Cardiology says that or is that chest physicians say that so major bleeding we define as causing hypoxia, hemodynamic instability, hemoglobin below 9 or 7, and then a drop that's more than 2 units of hemoglobin. And then a major site would be anywhere that you're going to be concerned about compressibility or like intracranial hemorrhage, pericardial tamponade, hemothorax. In terms of nosebleeds, I was reading that a posterior epistaxis would be considered a major bleeding site, and you would then consider these reversal agents or likely give those reversal agents. And we'll talk about that more objectively in a moment. What about your management for a patient taking apixaban or warfarin? Does that change? Do the reversal agents that you think about, does that change? Yeah, it could change depending on what you have at your facility. And then, are there any landmark studies that guide your management? So we'll talk about that. So the American College of Chest Physicians has came out with some guidelines regarding warfarins, and we'll talk about warfarin specifically. So warfarin's a vitamin K antagonist. And so typically we learn that you give vitamin K for patients who are bleeding or supratherapeutic. That was how I thought about it just generally in medical school. The guidelines say that from 4.5, an INR 4.5 to 10 with no evidence of bleeding, no major site, that they suggest against the routine use of vitamin K. You just stop the anticoagulant and they're going to follow up with their primary physician. Your patients taking vitamin K antagonists with an INR above 10, with no evidence of bleeding, you'd give oral vitamin K. And then for patients who do have bleeding, regardless of their INR, if it's major bleeding, if it's a critical site, you can give factor or 4-factor prothrombin complex or K-Centra, and then you as opposed to FFP. Some of the downsides of FFP are why you would give one or the other. I mean, head-to-head PCC did better, but also FFP needs time to thaw. And then there's all the risk factors that come with giving a blood product. And then for these patients also who have major bleeding, we'd give IV vitamin K, 5 to 10 milligrams, and it's by slow IV injection. So just reviewing again, we've got our factor 10A inhibitors. We've got our direct thrombin inhibitors like the Bigatran, which we don't see as often, but we'll talk about very briefly, and then warfarin, obviously. Just briefly going over the coagulation cascade, so we remember 2A or thrombin is what's inhibited by dabigatran. And so idrocuzumab is a monoclonal antibody that's used for reversal of dabigatran. There's I guess this study in which they looked at the reversal of dabigatran. They said within minutes you see the reversal of this anticoagulation effect. And this was, they looked at direct thrombin time as well as clotting time. Looking at our 10A inhibitors, the ones we see a little more often, Xarelto, Eliquis, those are 10A inhibitors. And so to think about how would you design a reversal agent for your 10A inhibitors, it would make sense if you just created something that looked similar to it without the anticoagulation effect and without its catalytic domain. So there's 2 domains on Andexanet that are different from the factor 10A inhibitors, and therefore then factor 10A, sorry. So Andexanet looks like factor 10A and therefore acts as a decoy. And so the factor 10A inhibitors will then consume the decoy or Andexanet. It's just 2 sites, like a serine to alanine change, not something I want to go too deep into. Yeah. The initial study, we're more so just looking at dose dependence of this anti-factor 10A or of the Andexanet. So for apixaban, you looked at the amount of anti-factor 10A that was in these patients after a bolus of Andexanet. And as you can see, for both apixaban and rivaroxaban, triangle is lower dose. So you saw in the square is the 420 bolus plus an infusion afterwards, and you saw dose dependence. So you saw less, you saw anti-factor 10A activity decreased as you increase the dose. In addition, they also looked at the regeneration of thrombin, and this was also dose dependent. This study came out prior to any patient studies, and the full study eventually was released, and they showed that 82% of patients who were given Andexanet had good hemostatic efficacy at 12 hours. Additional guidelines have come out that are very helpful for us. So when you have for example, when you have patients who have invasive procedure coming up, they're going to have some bleeding. So the concern is, what do you do? Do you give a reversal agent? Do you not? The recommendation is that you do give your reversal agents prior to invasive procedures where you would expect major bleeding. In addition, should these reversal agents be used in patients who don't have bleeding? And they say definitively, patients who don't have major bleeding, not at a critical site, you do not need to give, if they have a DOAC overdose, you don't need to give a reversal agent if there's no bleeding. And that's about it for case 1. We can move on to Dr. Wiener.
Yeah, so just to summarize, so for idarucizumab, the antidote is an FAB that binds up the drug, and it's available at both of our hospitals, but we don't really see that much dabigatran overdoses. But it only works against dabigatran because it's an FAB, kind of like Digibind or Crofab or something. Whereas the reversal agent for the 10A inhibitors is a decoy protein, so it works for all of the 10A inhibitors. And if you're not sure if a drug is a 10A inhibitor, all the 10A inhibitors have XA in the name. Like 10A, so rivaroxaban, enoxaparin, it works on 10A also. That's kind of a clue. Where we don't have that reversal agent at either hospital right now, although we're working on it. The problem with that agent is that they've priced it extremely high. It's $58,000 for a dose. So it's the recommendations are that you give it for major bleeding, life-threatening bleeding, but they give an option for Kcentra if you don't have Andexanet alpha available. And the problem with that is that it doesn't really look like Kcentra actually works in most studies, so it's a definitely inferior reversal agent. I should say the caveat that for both idarucizumab and Andexanet alpha, the studies that got them improved were not the best studies. They were uncontrolled studies that just looked at recovery of laboratory parameters and rates of bleeding, but without a control group to compare it to. But they are the best thing that we have available for both of those agents. So hopefully we'll have them available for major bleeding, but once we get it, you have to be careful to not use it for minor bleeding, or it's going to be a problem because it's so expensive. All right, so let me go on. I have some other hem-onc toxicology cases. First one, a 7-year-old mentally disabled child is found at home eating a blue-green rat poison pellet. The child appears well, has no complaints. What should we do to evaluate this patient? Get an INR. Should we do anything else? Okay. Okay, so what we're getting at is that most of the rat poisons that are sold in the U.S. are superwarfarins that are sold for consumer use. Just about everything that's toxic in the world has been used to kill rats at some point. But if you're going to buy something at Home Depot or something, it's going to be a superwarfarin. Cholecalciferol is used like on the subway tracks. It's basically vitamin D, and the rats die of hypercalcemia. But when we see patients with a product that was bought in an American store to kill rats, it's typically going to be a warfarin-like agent. And what makes them super? What's super about superwarfarins? Yeah, they last a long time. So they're very lipophilic, so they hang out in the fat, and so they last for months. So one dose can really anticoagulate a patient for a long time. So these are basically all the products we have. We think about GI decontamination. You probably don't want to be too aggressive about it, but if the parent can get a child to take some activated charcoal, it's reasonable. Most important is to check an INR at 48 hours, right? Because checking an INR up front isn't going to tell you anything if the child was just found eating the stuff, because it takes longer than that to become anticoagulated. You might want to get a baseline if maybe you're worried that the child's been doing this for a while and this is just the first time you caught them. But in general, the most important is to get a 48-hour coagulation profile. And if it's elevated, then you're going to start vitamin K. If they're going to need to be on it, they're going to need to be on high doses and for months. So it's going to be an ongoing process. So that's why you don't just start vitamin K empirically, because then it's going to take away your ability to see who's actually going to need it long term. And most patients don't. Most kids who are found with this stuff are found next to it and maybe didn't eat any, or maybe they put a little pellet or two in their mouth and they didn't take enough of a dose to actually get themselves sick. But you want to identify the ones that actually did, that are going to need the long-term vitamin K. So how would it be different if the child was found with pharmaceutical warfarin instead? Would you do the same thing? Bring them back for a 48-hour INR?
Depends on how young the child is.
Not really, no. Any age. Let's say they're 2.
It won't last as long, so that's at least one positive.
Yeah, so I mean, it takes a couple of days of treatment usually to get someone anticoagulated. So even if this is a high dose for a kid, they're probably not going to be anticoagulated from one pill. But even if the kid took more, you can just, unlike the situation with superwarfarins where you have this ongoing exposure because of storage in body fat, it's a single exposure and you can just give empiric vitamin K and not have to worry about it because it's not like you have to see who needs to be treated long term. So these patients can just be treated with vitamin K. All right, next. 46-year-old woman with a history of AFib presents with a lesion on her left leg. Anyone have any ideas what might be going on here? Ola?
Sorry. Quick question. About the previous case, so
Yeah.
we're not going with that guideline of 4.5 to 10. You don't do anything if there's no bleeding?
For which? For
For the INR, like this.
is this for the first case or for the child with the superwarfarin?
With the child with the normal warfarin, not the super warfarin.
So the child with the normal warfarin, I would just give empiric vitamin K and not have to worry about it. Yeah, and because it's not like the child needs to be on warfarin, because most patients who have a supratherapeutic INR who are on therapeutic warfarin are presumably on it for a reason, and you don't want to over-reverse them. But a child that's just takes somebody else's warfarin, there's no reason to not just give them vitamin K and bring them to normal. All right, so anyone have any ideas of the diagnosis here? Great, so this is warfarin-associated skin necrosis. And remember that warfarin, it inhibits 2, 7, 9, and 10, but also protein C and protein S. And protein C is the first thing to drop. And 1/3 of these patients will actually have protein C deficiency. From our perspective, the most important thing is to stop warfarin, and they may actually need surgical debridement, so that getting surgeons involved. Next case, 46-year-old man with chronic renal insufficiency had been admitted for 52 hours for unstable angina and is waiting for a telebed. He had recently been admitted to another hospital, and you get a call from the hematology lab with a panic value for platelets of 28,000. Okay, you're a step ahead. So what do you want to ask them, the admitting team? Is he on heparin, right? So, okay. So yeah, this is an example of HIT or heparin-induced thrombocytopenia. So say that he actually needs to consider anticoagulation. What can we do for this patient? Okay, good. So argatroban is what's actually FDA approved for this. There's fondaparinux is a possibility. It's another 10A inhibitor, an indirect one, but it's not FDA approved for this indication, but it's definitely another possibility. Leparutin used to be a possibility, but that's been off the market for a number of years. And there's bivalirudin is another one that has the same mechanism, and that's another possibility as well. Argatroban is hepatically metabolized, and the rutin ones are renally eliminated. So depending on the patient's ability to metabolize and their other illnesses, then it may affect which you choose to use. All right, next case. A deranged ER doc attacks a nurse he had impregnated and injects her with methotrexate. What is the treatment for the nurse? What's that? Folinic acid, excellent. So yeah, this isn't a hypothetical. This was one of my attendings when I was a resident at Monty. And yeah, this is fallout from the Christmas party, the department Christmas party. And yeah, he had gotten her pregnant and then attacked her in the parking lot of the hospital with a syringe of methotrexate. and then went back to the ER and put the syringes in the sharps bin to get rid of them because he was being responsible. So just to review, folinic acid bypasses where methotrexate acts. Methotrexate inhibits dihydrofolate reductase, which is necessary to activate folate. So it works downstream from there. There's some other treatment options. You can actually give thymidine rescue. It needs to be a continuous infusion in patients who are severely poisoned. There's a newer antidote called glucarpidase or carboxypeptidase, and that is an enzyme that actually cleaves methotrexate and inactivates it. So that's available only for compassionate use. It's usually for chemotherapy patients that have a massive overdose or something. You could consider it, but in general, folinic acid is going to be your primary antidote. Right, and so this patient got called into the poison center and got treated with folinic acid, and the baby was born healthy. All right, so next case, 66-year-old woman with non-Hodgkin's lymphoma complains of suprapubic pain, dysuria, and hematuria after getting chemotherapy with CHOP. What's a potential chemotherapy-related explanation for her symptoms? Excellent. So I hear two halves of it from opposite sides of the room. So hemorrhagic cystitis from cyclophosphamide. Good. Is there a treatment for it? Mesna. Excellent. So the EMIMs are shining today. Okay, yeah. So CHOP is cyclophosphamide, doxorubicin, vincristine, and prednisone. And the cyclophosphamide causes hemorrhagic cystitis. The treatment is fluids and Mesna. What if the patient had presented with shortness of breath and bilateral leg edema after getting CHOP? Okay, doxorubicin causing what? Cardiomyopathy. Good. So this is irreversible. There's no specific treatment for it. You just treat the CHF as CHF and you stop that agent. So this is my cat Thomas. He died 3 years ago after battling lymphoma for 3 years. He actually got treated with CHOP. It's interesting that for veterinary medicine, they use some of the same regimens that we do for human medicine. But interestingly, they don't get any of these adverse effects. I think it's because of the lower doses that are used. They're effective as chemo. He got 3 years out of it when his prognosis is a month when he was first diagnosed. But he really never had any adverse effects other than some fur loss. All right, next case, a 35-year-old woman with leukemia is being treated with a new regimen of Trisinox and Atra, or all-trans-retinoic acid, and she complains of palpitations and an episode of syncope. And this is her electrocardiogram. Jordan, what I overheard you say? Prolonged QT, yeah, so the QT is kind of long. Anyone have any potential reason for that? So if you didn't know what chemo she was on, then you would think about the platins that potentially could be lowering the magnesium or the calcium, and that could prolong the QT. But in this case, she's on Trisinox, which is arsenic trioxide, and this blocks your potassium rectifying current and causes QT prolongation and torsades. So that's a potential adverse effect of this new chemotherapeutic agent. All right, last case. A 55-year-old woman is rushed to the ER from the endoscopy suite after getting shortness of breath after an EGD. She's cyanotic, but she's not in acute distress. And these are the vital signs. She's a little bit tachycardic. She's a little bit tachypnic. Her SAT is 86. She gets 100% non-rebreather put on, and it goes to 87. Rest of the exam, she's got clear lungs. Exam's otherwise normal. What do we think happened here? Methemoglobin from what? Yeah, the hurricane spray, not lidocaine. So what should we do? Okay, so potentially methylene blue. So I think I've talked about this a number of times, but remember methemoglobinemia is oxidation of the iron in heme. And in addition to taking away oxygen binding sites, you lose your cooperativity. So the methemoglobin is less able to deliver oxygen to the tissues. In terms of common culprits, local anesthetics are really common. Any cane except for cocaine can do it. But hurricane is the biggest offender, and it's not clear if it's the chemical or the delivery system. Has anybody here used hurricane spray? They've taken away, it used to be out everywhere in the ER because we'd use it for NG tubes and things like that. But it seems to be a lot less common these days. For someone who's used it, can you tell me how you use it? Taylor?
It tastes like bananas. You just like spray it. How long do you use it?
Yeah, so you're supposed to hold it like 10 inches away from the area you're anesthetizing and give like 3 bursts, but people tend to kind of and it kind of foaming up in the back of the mouth, and so it may just be that people get a huge dose every time this is used, but it's a really common offender. Antibiotics are also common offenders, sulfa drugs, dapsone, pyridium that we give sometimes for UTIs, right? When you tell people that they can take it for 3 days, it's because if you take it for more than 3 days, you can get methemoglobinemia. And then nitrates and nitrites. There's actually a huge list of things. These are a larger list of common ones. So kind of clues, that kind of chocolate brown blood, although now we're not drawing blood anymore in the ER, from what I hear. So maybe we won't see this, but the nurse may tell you. And again, a marked cyanosis, often without signs and symptoms that you would expect from somebody that's that cyanotic. If you do have signs and symptoms, it's from tissue hypoxia. So how much methemoglobin does it take to be cyanotic? So how much deoxyhemoglobin does it take to be cyanotic? When we think about like blue pigments making somebody look blue. What's that? Yeah, so grams per deciliter is the unit. So 5 grams per deciliter of deoxyhemoglobin makes you look cyanotic. So the amount of the blue pigment that it takes in a percent depends on your total amount of hemoglobin, right? So if you have a total hemoglobin of 15 grams per deciliter, which not that many of our patients do, then by the time a third of it is deoxyhemoglobin, then you have 5 grams per deciliter of deoxyhemoglobin and you look cyanotic. So somewhere when you start to get below 70, that's when the patient starts to look cyanotic, right? But methemoglobin is a stronger blue pigment, and it only takes 1.5 grams per deciliter of methemoglobin to make you look blue. So if your starting hemoglobin is 15 grams per deciliter, then it only takes 10%. Everybody get that? All right, cool. So the kind of clue for methemoglobinemia is you see a low pulse ox, but a normal sat on the blood gas, because the blood gas sat is calculated from the PaO2. And in general, on a pulse oximeter, you should see a sat around 85%, because methemoglobin absorbs at one wavelength like oxyhemoglobin and at the other wavelength like deoxyhemoglobin. And the higher the percentage you have, the more it tends towards 85%. So diagnosis, cyanosis, pulse ox near 85% that doesn't improve with oxygen, normal cardiopulmonary exam, normal sat on blood gas, and a history of exposure to oxidant stress. But the definitive diagnosis is co-oximetry. And again, the amount of symptoms you have from methemoglobin depends on your total hemoglobin. So if you're anemic, you're going to not tolerate as high a percent of methemoglobinemia. Treatment, A, B's, and C's, remove inciting exposure, and then methylene blue. Methylene blue needs to be reduced to leukomethylene blue using reducing potential from NADPH before it can be an active antidote. Who doesn't have a lot of NADPH around? Patients with G6PD deficiency. So if somebody has known diagnosis of severe G6PD deficiency, you should probably avoid methylene blue because it by itself is an oxidizing agent before it's activated by NADPH. You should never withhold it because somebody's from a genetic group that has a high incidence of G6PD. It's for a known diagnosis of severe G6PD. For time, I don't want to spend too much time on the dose because you're going to look it up every time you give it. But people make mistakes because they forget what percent means. And remember, 1% means 1 gram per 100 mLs. When people get that wrong, they sometimes make 100 or 1,000-fold dosing errors. If you're reaching for more than a 10 cc syringe, you probably did the math wrong. So just kind of keep that in mind. So in general, this is one of my co-fellows, Heather, with her patient that had methemoglobinemia before and after methylene blue. It works pretty quickly. Take the pulse ox off when you're about to give methylene blue because it's going to drop and it's going to freak everyone out. Just so you know, because the blue pigment also confuses the pulse ox. If it fails, you probably didn't give enough, or you're having ongoing methemoglobin production, or something called self-hemoglobin, which is actually oxidation of the ring part of the heme instead of the iron. That doesn't really respond to methylene blue, and it's just supportive care. And severe G6PD deficiency that's been undiagnosed is another potential reason. Joel?
Yeah, for an adult, I just give 7 cc, which assuming it's kind of dead, it's not going to really hurt them. So I just remember 7 cc's, and that's what
That's if you're 70 kilos. That.
In a kid, I'll calculate.
Yeah.
But in an adult, I just give 7 cc's.
That's fair. It might be an undertreatment if somebody is
Yeah.
significantly larger than that, but yeah. All right.
But I never go over 10 cc's.
Any questions? Ben?
I'm just curious about transfusion in patients who are like anemic but also have like a methemoglobinemia. Is there any like role for giving them back normal blood?
Yeah, absolutely. I mean, I think that that's totally reasonable. I mean, if it depends on how low their hemoglobin is, but it's certainly something to consider. If they're symptomatic and are anemic and have methemoglobinemia, you would still want to treat the methemoglobinemia if they're somebody who can get methylene blue. But certainly transfusion is also going to help alleviate their symptoms. But remember that if they're continuing to get that drug, they're going to be continuing to make more methemoglobinemia. So that's going to be an ongoing process until the drug's been eliminated. But it's not like a consumptive coagulopathy where you're adding fuel to the fire or something. It's giving more red blood cells isn't going to make it worse. All right, thank you.